بسم الله الرحمن الرحيم. الحمد لله رب العالمين. الحمد لله الذي هدانا لهذا وما كنا لنهتدي لولا أن هدانا الله. اللهم صل وسلم وزد وبارك على سيدنا وحبيبنا وشفيعنا سيدنا محمد صلى الله عليه وسلم. يسعدني اليوم أن أقدم أستاذي الجليل المتفرد بعلمه ورقيه وإنسانيته المفرطة، يطلق عنان فكره وكذا حافظة نقوده، ويبذل كل ما يستطيع لكي يتعلم كل شيء جديد، مولع بالترقي في العلم والحصول على أكبر قدر من الخبرات. شخص استثنائي يحمل بداخله لينا وإنسانيات بديعة، وتطرب أذنه لمهرة القرآن الكريم، ويحب الشعر والحيوانات الأليفة. أستاذ الدكتور ياسر رضا. كما يسعدني ويشرفني ومنبهرة بشخصيته الطيبة اللينة الجميلة الراقية، والذي أطلق عليه واكتشفت أن الدكتور سعد مهدي يشاركني نفس اللقب، سمو البرنس دكتور هيثم الجميل. أهلا وسهلا بحضرتك، ومبسوطة جدا بمشاركات حضرتك النبيلة، ومنتظرة الكثير والكثير. ومنورنا النهارده في المنوفية أناثيزيا بين اند اي سي يو كلاب، منور الدنيا كلها. سعادة البروف النبيل Your Highness and Majesty بروف هيثم الجميل. تفضلوا يا فندم، تفضلوا يا فندم، تفضلوا.
Actually, it's difficult actually to grab the words and to collect the words after what Dr. Safa mentioned. Dr. Safa actually is a very nice person, not only as an anesthetist and not only as a professor, as a friend, and as an outstanding personality that definitely affects and try to provoke efforts in order to do her best for everyone. I'm so delighted actually to accept this very kind and very really valuable invitation to be a moderator in one of the outstanding scientific meetings. I've never been in Manufaya before, by the way, and I was really thinking about how much I could do in order to pay back those kind of very kind words that I actually don't deserve it from Dr. Safa. But to be honest,
really you deserve more and more.
Allah يكرمك Dr. Safa, and I have no doubt actually that this kind of efforts and the one actually she stands behind all of this very nice and very marvelous arrangements of this kind of course. Definitely, Dr. Safa, she deserves all the best, and I would really highlight all of her efforts, and I would appreciate really her kind invitation in general. To be honest, I'm very honored as well to be selected as a moderator of this scientific session, because actually it carries a heavy weight of scientific achievements from a person who definitely have a very wide and very deep knowledge. I think, to be honest, it's difficult actually to speak about regional anesthetics or the field of pain management without considering the Dr. Yasser's achievements. For all those who didn't know actually Dr. Yasser is a very nice person, but apart from the behavior and apart from really the knowledge, he's very keen and very initiative to conduct his experience and his education, his training for all of his junior colleagues. And definitely this is, to be honest, is quite apparent and apparently very significant whenever you check any study or when you check any kind of medical or like educational achievements in one of the main courses that have been really wrangling around the Middle East. Definitely, you should never be surprised to find the name of Dr. Yasser, either whether he wants to achieve something or whether by his contribution as an educator or as a teacher or as a trainer for all of his junior trainee. Moreover, it's in a highly selected manner. I think we choose to get more information about this field of regional anesthetics, and Dr. Yasser is a superior. And to be honest, he's a pioneer in this territory. He's considering this regional anesthesia his territory. And perhaps all of you knows that sometimes regional anesthetics, sometimes the pain management, and especially whenever we deal with a very complicated cases, that when the general anesthetics, or let me say that putting down, knocking down the patient down to sleep, would be difficult, would be critical, would be contraindicated, then the regional anesthesia is the shelter. And to get someone who have a very good experience and very superb experience in the field of regional anesthesia definitely is carries a lot of valuability for this course. Dr. Yasser is not only the expert in the field of in terms of regional anesthetics, but even the pain management and even in anesthetics. And this actually is very obvious in when we go through his achievements and his certificates and his qualification. His expertise in this field actually, and his knowledge actually has been proven throughout the many years, and we very well acknowledged as well through different achievements in many courses and in many contribution and actually there is enormous number of achievements in the form of the highly qualified qualifications and loads of qualification in the field of regional anesthetics, and also he get many certified training programs as well in this field. Dr. Yasser, he's actually been, let me share this with you, because actually it needs someone who can, it's difficult actually to grab all of those data, but I would really be delighted to give me your attention with it. Actually had a plenty of achievements starting from the national and international and even European diplomas. He had the Arab Board of Anesthesia and ICU, European Diploma of Anesthesia and European Diploma of the Regional Anesthetics as well, European Diploma of the Pain Medicine. He's been certified in the intervention pain sonography. He's have a fellowship in the intervention pain practice. He has the ASRA in pain and the ultrasound certification in MSK. He has the ozone therapy diploma as well, which is very, very, very interesting. He has the American board, so he crossed the borders, he crossed the oceans to have the American board of headache in the USA. He has published many papers and plenty of edition for many pain blocks and in the pain books as well. He's the speaker and a faculty member in many local and international conferences, workshops in the regional anesthesia. You will never be surprised, to be honest, when you see that Dr. Yasser actually has been achieving all of that by a very prompt achievements through his contribution, either in the international and national conferences, or even by getting all this certificates and qualification by sitting for the exams. And you'll never be surprised when if you went, mashallah, to one exam and you found Dr. Yasser there is actually as a candidate. And that actually reflects how he's very keen and he's very eager to learn more and to improve himself and to enrich his career by those achievements. And if you start to discuss anything with Dr. Yasser, definitely you will discover that you're a little bit far behind what he knows and what he did as well. And personally, I'm talking about my personal experience. One day I just went and asked him about the application of, the implementation of regional anesthesia in the field of the cardiothoracic, which is my territory or my subspecialty. And I found him, he did this for a couple of times in Hamad Hospital. So I just, to be very close as well, I think Dr. Yasser can share some picture as well, or we will share some picture about Hamad Hospital, just to know more about where he works and where he did most of his achievements as well. So Dr. Yasser currently work as a consultant of anesthetics and of regional anesthesia and pain management in Hamad Hospital in Qatar. And apart actually from being a consultant in Qatar, Dr. Yasser is actually his existence and persistently existent everywhere in the Middle East. And probably you will not be surprised to find him actually have his own achievements and his own participation and contribution, even in overseas as well, crossing the oceans and throughout the international achievements. Today, Dr. Yasser will speak about how we can manage the shoulder pain, chronic pain in the shoulder, how we conduct regional anesthesia for and the pain management actually for shoulder pain especially. And I think it's going to be very, very, very rich and a very, let me say, very valuable and very profitable for all of our junior colleagues and for me personally as well, because I have a shoulder pain, by the way. So I'll be really very excited actually to know more about that from Dr. Yasser. I think he will be the best to tell us about that. Dr. Yasser, over to you.
Thank you, Suraisam. Today I get a gush of nice words, so really I'm having a good feeling about this presentation, but I'm happy also to come to a Monofia Club meeting to present my presentation and be happy for presence of Dr. Haitham. I know him as a friend, and thank you for Dr. Safa for a great work. Dr. Safa is the house power of the cells, like a mitochondria, make a great activity, and I'm just happy to share this activity because this is like a zakah from my what I learn, what I get for my junior staff, and this is a road just to protect our patient usually to make a safe practice. So my presentation today is about shoulder pain from anatomy to ultrasound diagnosis and intervention. But I get thank you for invitation of Dr. Safa, but Dr. Safa said that most of our junior, when go to the exam and the examiner asking him about pain or chronic pain, he gets shocked. But you know that chronic pain is another concept away from acute pain. And I will just try to make a hint. This is like a two presentation, two in one. A small hint about chronic pain management, and I give you as a shoulder pain as one of the example of pain, how you treat, how you diagnose it. So really, this is a picture from my hometown, Russell Bar, and I know most of you know it, and I hope one day to return back to make an activity there and to invite you all. So I don't have any conflict of interest, and I don't have any support from any company or any society, financially or moral or anything. So my agenda in this presentation, I will just give you some to open a gate for how to know the chronic pain, how to treat the chronic pain, and when you got in the exam, when anyone asks me acute pain, chronic pain, you must know some valuable knowledge about that. And I will just give you an introduction about the chronic shoulder pain and what's the implication about it, and updated anatomy and the variation in anatomy, because anatomy is like a fingerprints, different from one to one, and how you see this anatomy by ultrasound. And I give you some hits about how to make a successful block. And at the end, I just will go to the home message just to remind something about my heavy meal. And this is like an eating a camel in 1 hour. So I will just try to make as fast as possible as I can to cover the subject, and as short as possible as I can, and not to get bored and to no sleeping. At the end of this presentation, all valuable junior, you must know what is the meaning of chronic pain and what is the difference between acute and chronic pain. To get some idea about the shoulder pain, shoulder anatomy, and how this structure make a pain generator for the pain, because the pain came from shoulder from different parts, and really it is not one shoulder, it is for a joint. And how can we see the anatomy or pathology of shoulders, and how to diagnose the pathology by ultrasound, and what is the type of intervention for each pathology, and at the end to give you a clinical barrels of the each of intervention. So you know, all of us know the definition of pain, which is published by WIB, World Institute of Pain, and he said unpleasant sensory and the emotional. We must remember all the time that there is an emotional implication for such pain, and associated with actual or potential tissue damage or described in terms of such damage. I make it a little difficult because it's confusing. And I see some people just make another revision for this International Association of Study of Pain, and it's published 2020 about the new definition. And unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. This definition put more and more confusion. I don't know what is, how can you explain it? But all the time you must what's called don't ignore the what's called moral and psychological problem of pain. And no, the pain is more terrible lord of mankind than the death. Sometimes the punishment or torturing or a pain is more than the death. Some people ask to be die more than to feel this pain. And the difficulty with pain is the measurement is very difficult. It's not like a blood pressure. It's not like a blood pressure or like other things to measure from lab tests, but the pain is subjective and difficult to quantify. So the same pain expressed by different subject as different type of pain or just a different severity of pain. And we have a problem just to measure pain all the time because depend on subjective sensation. But in simple word, that pain is subjective, come from the person, and usually underestimated for us because usually we believe what we see by our eyes. So we don't see the pain. Sometimes we don't believe deeply in pain. So the problem is being underestimated, and because it's underestimated as undertreated. In simple definition, if you see this bread, it looks like sad and have a pain. And if you look for this barrel, even with one eye, it looks like happy and don't have a pain. And the wisdom that no pain, no gain is not right for it may be for our life. When you get some pain, you change, or just the pain change you, or just helping you to change to make more gain. But for our pain management, for our chronic pain, if you have pain, you never have a gain. You have a disability, you have a problem all the time, you have a deficiency, you have an absence from the work. Social life is not good, sleeping is not good, everything is not good. So at the end, the pain is also leaving the body. If you have a pain and you are still young, you can feel that you are very old. And you must differentiate between different type of pain, between acute pain, chronic pain, and malingering. Some people malingering was called, he shows that he feel a pain and he don't have a pain. And this being gainer, he gained by his pain. He gain a sympathy, he gain money, he gain a compensation, he gain everything. And other thing, when you get some chronic pain, which is not in your specialty, like ischemia and the cardiac pain all the time, or chest pain, because other stuff, and you must discover it and send fastly for the people attending this specialty to help him. So chronic pain statistics, chronic pain, one of the most expensive surface all over the world. And in America, usually measuring everything by money, and even sometimes the economy pushing for studies. So you must know that 1 over 5, and Americans about 400 million, about 1 over 5 from the survey have one of chronic pain. So if you have 5 persons, you have one feeling pain. And 60 million number of people suffer from worldwide. You can just found the big number. And the cost $63.5 billion from this pain, management, the compensation, absence of work. So they count everything. And in a survey for chronic pain, they found that 11 to 40% of the people complaining at any part of their life by chronic pain. And most common type for chronic pain, which is low back pain, the most common, headache and migraine, neck pain, facial pain, and other type of pain, it may be less. But if you count that 60 million have a pain, even 001 is a considerable number. So this is just how they spend the money for the physician, for compensation, for medication, for absence from work. And at least 77.8 billion spent globally for chronic pain annually. It's a very big amount of money. And worldwide is 1 in 4, like in America 1 in 5. And 85% of chronic pain can be affected by depression. Usually the chronic pain started as acute or started as a chronic from the beginning. The patient anxious first about his pain, what is the cause of pain, and asking a lot of questions about his pain. But later the patient become depressed, and many patients commit suicide, like in people for migraine. And I was surprised to know that the cluster headache, the mortality with suicidal tendency is about 20%. So 1 every 5 person get and commit suicide because of chronic pain. And also chronic pain just pushing the era for overdoses and narcotic use, especially in America. For 2017, 191 million opioid prescription was dispensed for American. You can see how it's big number and how it's big and what's called a narcotic crisis because of chronic pain. The common pain here, back pain is the most common. And most of us, about 90% of us have a back pain at any type of his life. It may be an injury or trauma and progress to persistent most of the pain. Maybe cancer can give you a dynamic pain. Dynamic in everything, in the character, the severity, in everything. So the cancer pain is dynamic, and because the cancer is dynamic. Arthritis, many of us have an arthritis and have a joint pain. Migraine is very common symptom, especially in female. Fibromyalgia, common in female more than male, but if it comes in male, it will be more severe. Diabetes, neuropathy, and the other type of pain. So as I told you, that 85% of patients with chronic pain are affected by severe depression. So you can't treat the pain without treating the psychological aspect of pain. In the poor country, it may be the incidence of chronic pain not far from America. It was be 1 in 4 person got a severe back pain or just a headache or any types of other pain. I tell you, in chronic pain, the suffering woman is about 22%, the man is 19%, but really if you come to the male, it will become more severe, especially fibromyalgia. Fibromyalgia, an incidence between female and male is 7 to 1. But I have few patients here that whatever you give him, he don't get any relief. And it is a great problem. And you know what is the stages of life of person? So you mean don't have a pain, but you have a predisposing risk if you get acute pain, chronic pain. And chronic pain changes to acute pain changes to chronic pain. But don't remember that the chronic pain is not continuous acute pain, it's different everything. And if this chronic pain is not treated, it becomes intractable and get a very poor outcome. So the pain pathway, all of you, you know that pain pathway. If I get a needle break in my foot or my finger, this transmitted through the nerve to dorsal root ganglia and jumping from 1 to 4 or 5 segment and go to the other side and express in the brain. So this is the pain pathway, and the brain just localize the pain, give you pain character, give you the withdrawal reaction, and also make a memory for such pain. If you get a renal colic, and after that you get a renal colic, you know the same pain. But remember that the pain is not just in one way. There is a descending modulation from periaqueductal gray, locus ceruleus, descending neuromodulation by noradrenaline and serotonin, try to inhibit the pain again. So you feel a pain at any time of the age of your life, and this pain, if I ask you after 1 year, 2 years, you don't remember which pain, which type, because there is a descending pathway which inhibit the pain processing, or just sometime this system become crazy to express more and more pain and to change the chronic pain. So as I told you, acute pain is a different concept from chronic pain. So what we know and what we don't know about the pain is like a tip of iceberg. We know a little about the pain, even with this technology, with achievement for research. But remember, this is a plastic bag, not an iceberg. So if you look for the pain textbook, you found a very complicated diagram, how it's been started, how being processed, and why the pain character, sometimes burning, sometimes stitching, sometimes numbers. And if you look for this graph, you found many mediators, not just one mediator, many mediator, and every mediator, when excited, gives different type of pain. For example, if you have a shooting pain, one of the medication like carbamazepine is more effective. But if you have a stitching or burning pain, maybe tricycline and depression, amitriptyline, gabapentinoid is more effective, because there is a very complicated understanding of the pain and how it works. And all the researchers study just showing that we make a targeting one of this site. And because of that, we don't have a complete relief of pain, because there is many sites for processing the pain. But the important thing about the chronic pain is the brain. So if you don't have a brain, you don't have pain, because expressing this is a signal transmitted and signal coming back came from the brain. So how this acute pain changes to chronic pain? I told you that chronic pain is not continuous acute pain. It's different in everything, different in mechanism, different in expressing the pain, different in management and the target of management, so different in everything. So what happened? That happened central sensitization in the brain. If I get a pain and the patient have a predisposing factor, maybe genetic, maybe social, maybe culture factors, and this patient subjected to change this pain to another type of pain is called the chronic pain. And chronic pain different in everything, in mechanism, in diagnosis, in markers, in management. And at the end, what's called get an neurogenic inflammation. Neurogenic inflammation, just like a whispering for other side to increase the receptive field, to increase the pain. And this is what's called malfunction of the central nervous system. So this graph is a little very complicated, but I just make it easy for you. So for post-operative pain, it will become continuous. So looking first for injury, first thing to happen for trauma and for anything, an injury. And this injury make a nervous sensitization, become more sensitive. And this will lead to central sensitization in the brain spinal cord. And the patient have a pain experience. And if not resolve it, it can get a pain cognitive process, depression and anxiety, cortical reorganization, which increases the receptive field and responding without pain. And avoiding disabilities, the patient avoid everything, avoid life, avoid work, avoid even to moving the painful part, and you get a muscle spasm and fibrosis and decondition. So if you try to classify the pain, there is many classification, but in chronic pain, you know that the pain may be nociceptive, came from like a trauma, like a surgery. Neuropathic just come from the nerve, which have a tingling, shooting, or numbness sensation. It may be an continuous or just like a visceral pain, like cancer, head of pancreas, or pancreatitis. And this pain become visceral and become chronic. And if you have the three type, you have the HELP. So the difference between acute and the chronic pain, not like between a green apple and red apple. It's totally different. This is like between apple and orange. So the acute pain, this is in this graph, I just try to simplify. Acute pain, usually obvious tissue damage. You have a tissue damage, you have and something behind, you have a diagnosis. But in chronic pain, usually a pain beyond the expected time of healing, and also sometimes you don't find any cause. You found a healing, but you don't have a pain, but you don't find any apparent cause. Usually acute pain is a protective mechanism because if I put a needle in your hand, you just withdraw his hand. It's a protective mechanism. But really in chronic pain not longer serving any useful purpose. As I told you, no pain, no gain is not for chronic pain. Increased nervous system activity. And this activity promotes the descending pathway to decrease the activity. But in chronic pain, it changes the pain signaling itself. So continuous signaling and without any apparent cause. Pain resolve if the healing happens, most of the people, this acute pain, it become healed, and sometimes it's pushing you for seeking a medical advice. But in chronic pain, it degrades the health and the function of the person. So in acute pain, very easy to be treated by a single physician, but by chronic pain, it needs a multidisciplinary technique because every effort needed just to treat the pain, even the effort of the patient. So what is the definition of chronic pain? Persistent or intermittent? I don't care. And that lasts more than 3 months. You know, this definition is accepted by most of the physicians, but many other definitions about the chronic pain. But make it simple, you know, the pain behind the healing process or the pain stay more than 3 to 6 months. So when you assess the pain, you must look for the type to treat it, severity of this pain, localization, because you know when I give you a character of pain, if you're asking this question, you know where is the pain generated? An onset, acute or chronic, traumatic or not, duration, how many months to see this chronic or not, radiation, like where is radiation, exacerbation and alleviation factors. And also there's many facts about the chronic pain. As I told you, it is not non-pure. For acute pain, I need just the target to relieve the pain. But for chronic pain, you don't find any complete cure, especially in most of the cases. And usually it's self-diagnosed. And most of the time, if I go for lab tests, I don't find any abnormality in lab tests. For example, acute pain, I can find what's called the stress hormone coming up. But in chronic pain, I don't find anything in lab. And also sometimes I don't find anything in imaging, whatever you use in image. who can last 3 months. And usually, as I told you, more female more than male. But I must ask myself some question to go for the pain. What's the pain and what pain generator? So what causes this condition for a chronic pain? And is there any hereditary effect like low back pain running between families? Because you have a genetic factor. Which precaution should I take for this condition? And which tests I need for this gentleman? I don't find anything in the lab, or so I look for MRI or CT or ultrasound. And is the condition curable or not? And the treatment option is what's available. So just if you have a severe pain, this pain have an anxiety first and can treat it or just to progress for chronic pain. So most of the chronic pain started mostly as acute pain, but in some cases it starts as a chronic. So the symptoms of chronic pain, that persistent pain, patient suffering a lot from any part of the body, or just like low back pain or fibromyalgia or whatever. It may be pain joint, mouth, and face, according to the type of pain. Decreased function. Most of the time, the patient come ask for sick leave and stuff like this. And you can know that in America, only on back pain, there is absence of work about 28 million days per year. So the country lost 28 million productive days for their isolation. The patient started by anxiety and ended by isolation and depression and fatigue from everything, and he can't sleep good. So the main diagnostic tools for that chronic pain is a physical examination and medical history. Most of the time, they clear everything. Sometimes use an imaging like X-ray, if you have a tumor or fracture, MRI, CT scan. If you have a lab test in fibromyalgia and diabetes mellitus, because this is a sign of, this is for exclusion, not for proven. For lab tests, I can make a rheumatoid factors test, systemic lupus erythematosus, like anti-nuclear antibody, because you need to exclude, because diagnosis of fibromyalgia is by exclusion. EMG in some cases, but very rare, to check whether any severe damage, to look for what is the pain generator. At the end, for one of the most good diagnostic thing is diagnostic test. Sometimes I don't need anything, it's just I make and inject this part of the body because I'm thinking that this part of the body is the origin of pain, so I inject this part, and if you relieve pain, and it's a positive diagnostic block. So what's our target to treat a chronic pain? What's the target? Is the target to relieve the pain completely? This is not the target, because we can't do that. But the target is to improve psychological state, and we need the physiotherapist, psychotherapist, decreasing the pain score, and they need a pain physician, improve function, they need physiotherapy, improve sleep, it may come from relief of pain or with psychotherapist, and pain coping, and this is patient doing by himself. So this increases the quality of life. So as you see here, for target of management, you need a multidisciplinary team, like a psychotherapist, physiotherapist, and you know that you can't make a pain surface without psychotherapist and physiotherapist at the next door. So managing of chronic pain, sometimes difficult. It is not one-man show, and need a multidisciplinary team, and the patient must take a role for coping, for some aerobics, for some yoga, for some like meditation and biofeedback to help himself to treat his pain. So with chronic pain, you know that there is many guidelines came from WHO, like a step-ladder system for cancer, and can be practicing for cancer or for non-cancer, how to escalate your medication and do this according to the pain. But still, the treatment of chronic pain may be medication, the first line, or conservative management, physiotherapy and psychotherapy. Alternative therapy like cupping, massaging, needling, or meditation. Regenerative medicine now is an era of regenerative medicine, like injecting polarotherapy or BRB or less stuff. Diagnostic block, maybe diagnostic block, and maybe prognostic, because sometimes you make a diagnostic block for local anesthesia only, can stay for many months or years. Electrical, like spinal cord stimulation, peripheral stimulation, radio frequency, pulsed or conventional, and ablation, especially in cancer patients, is chemical or electrical. We don't do that ablation usually in benign pain. So I'm just going, if you fail all the management, don't get more from the conservative management, just go for intervention. And indication for intervention, like medical treatment issue, the patient can't tolerate, not durable with the medication, or just availability of the drugs like narcotics. Patient issue, this is a very important. If the patient not durable with the medication, or just have a severe side effect of medication, or have anything to interfere with the conservative management. Condition issue, if you have an what's called an condition like, for example, like cancer rate of pancreas, this patient need an intervention rapidly before even the tumor coming out from the capsule. And the hospital issue, if you have an hospital facilities, you have an issue, and what's called the physician issue, if you have experience to do the procedure. So the indication, failure of medical treatment, intolerable side effect of the medication. You have a good result, but the medication makes the patient to sleep all the day. Patient durability, some patients don't like to take a medication all the time. And sometimes patient request, I will not take any medication, I need intervention. And good experience with the block, and to have a good hospital facilities. Contraindication of intervention, as you know, the occlusion anesthesia, coagulopathy, but this is a broad term. Because if you look for the INR, by definition, 1.2 is coagulopathy and 3 is coagulopathy. So you can't judge if this the procedure don't have a bleeding or just you can compress. So coagulopathy, pre-existing neuropathy. This is for medical legal aspect, because whenever you make a block and the patient have a neuropathy, you have a problem and must document that, and for a medical legal purpose. Anatomical aberrancy for if I needed to make a block and the tumor eating the area and they don't have any anatomy, or the people with drug-seeking behavior. If the patient is addict or drug-seeking behavior, whatever you did for him, he will not relieve, because he must be treated psychologically first. Very related to psychological problem, I have a patient, just if the patient psychogenic, this patient feel a pain. I mean psychogenic, not malingering. Malinger, he don't have a pain and showing that he have a pain for compensation. So he gained by his pain. But for psychological pain, I have a patient, she saw her dad dying from cardiac attack and have a severe shoulder pain. And he said that I feel that a tank in my chest, and died after that. So this lady all the time coming from this pain, and we do everything for her. But she don't have a pain, 24 years old. And this is called psychological pain. Already this lady feeling the pain, but with no reason, but the reason is psychological. Pathology at the injection of infection, lack of experience is very important. Don't make a block and you don't have a experience for that. So this is sorry, I'm just very sorry. This is the first part of the presentation. I will try to go faster. As shoulder pain is one of the chronic pain, maybe second or third incidence. Every day I see in my clinic, I see, for example, from 15 to 20 patients, I have at least 5 patients from shoulder pain. And most of us have 70% from shoulder pain in any time of our life. Mostly, and this is alhamdulillah for that most of the pain can improve with conservative management. But some patients don't control by my conservative management, so you need other modality of management. So shoulder pain in population about 7%, increasing with age. For example, older above 70 have 26%. Usually the pain moderate to severe. It is one of the severest pain you can find even in surgery. Shoulder pain is the most expensive procedure. If a patient make an operation, mostly after operation, you get a chronic pain. So, and very rare to find, the incidence is mostly not came from emergency, like a trauma, like this gentleman. It don't come from this is trauma. Usually from repetitive movement. You don't feel, you don't lifting a heavy weight, and all the time you don't have a trauma, but this pain increasing steadily because it's coming from what's called trauma due repetitive movement all the time. And the referrer of chronic shoulder pain sometimes misleading, and the surgeon before you misleading, especially if he make an MRI for the neck and found a disc. Not every disc he can produce a pain, but most of the time, if you want to differentiate between shoulder pain and neuropathic pain, the shoulder pain usually nociceptive, it's like a trauma pain, like a surgery pain, and neck pain mostly is radicular, like a numbness, tingling, and refer to the arm. So it's very important because I have many patients going for the surgeon and telling him you have an neck problem and must make an operation. And when he come, I found this shoulder pain, and you must remember that shoulder pain follow the neck pain like a shadow. And when I make injection, this patient improved. So mostly I'm looking for what is a pain generator on the shoulder because it's a very big joint. It's half 4 joint. It may be inflammatory, post-traumatic, rotator cuff. The most common is rotator cuff arthropathy, especially supraspinatus muscle tear or just tendinosis. Sometimes what's called an calcification or infection. In infection, I don't need to inject, but in most of other type, I can help. I'm just not going for that because the time. What about the diagnosis? Because we speak about the chronic pain, how to diagnose it. It's one of the first is the history and examination, and you must get a rapid communication with your surgeon, with your patient, and he must trust you about what you said. So history and physical examination, there is many tests to examine your shoulder, like this is one of the tests, to make attention on the shoulder, like hand on head test, put your hand on the head and without bending your neck. If you feel a pain, it is a shoulder pathology. You can, what's called pocket sign, you can put your hand in back pocket, and if you feel a pain, you have some pathology. Or just you make what's called a scarf sign. You put the hand on the other shoulder, your hand, right hand, for example, left shoulder, and you can feel the pain. Investigation, hardly X-ray can show anything except a fracture or eating the joint, but mostly they have a very little predictive value about the shoulder diagnosis. MRI is a very good tool, but the problem with MRI is not dynamic. You get a slides of pictures. Sometimes if the pathology between the slide, you can see it. In some cases, we need what's called dynamic, as you see the video, dynamic examination of the ultrasound. That's very, very good tools and can show a lot of stuff. But the problem with ultrasound is not a time consuming, not a radiation, not a claustrophobia. But the problem here, you can see what's behind the bone because your ultrasound can see what's behind the bone. What is the diagnosis of this gentleman? And I think Dr. Asfa, no, without ultrasound. So it is his wife, no password of his mobile phone. So as we said, that pain management is patient rights. It's not a privilege. So every patient must have his right to be treated. And the treatment of shoulder pain is not one fit all. It's different from space to place according to experience, availability of the drugs, the conservative methods. And at the end, we need to fix the problem in the shoulder. But remember that safety is paramount. Safety is very important because your aim not to hurt the patient. You no need to treat him, but don't hurt the patient. And we are looking just in the era of evidence-based, and according to our recent study, we know that the marriage is the main reason behind the divorce, and this is well known. But remember that absence of evidence is not evidence of absence. Sometimes you don't have an evidence because you don't have enough study. So can we get our shoulder to be like this gentleman or like this lady? Yes, we can. What is the management? The management, as I told you, conservative management is very important by pills, modulation, by pills or just by stretching exercise or by even changing a lifestyle. If you change your lifestyle, it can help you on management. Exercise, very important, but to be suitable for your shoulder, not to make an extra exercise. Physiotherapy is, as I told you, don't open pain surface without ultrasound, without physiotherapy or psychotherapy next door. Massaging was another alternative, different type of massaging. Meditation, like what's called to distract yourself away from your pain and to relieve anger and anxiety, depression. Needling, cupping, aerobics, it will help a lot. Biofeedback. Yoga, but you don't necessarily to go to this place to make a yoga. You can make it in home, like this one. But don't forget the other part of the treatment of pain is the psychological determinants. Whatever you give the patient without treating his psychology, you have a problem. And this patient pain catastrophization is very important to treat for chronic pain. And also to discuss with the patient an appropriate illness and beliefs and fear avoidance, because he fears from something until he gets his shoulder frozen, can't use it, depression and anxiety, and they must make him a job dissatisfaction, which is very difficult to do. And to treat this disability, whatever it is, a mental disability or just a physical disability. And I think something will come in the near future to give us like an polarotherapy or it's called degenerative medicine. And don't forget that some cases is not your cases. Some cases need a surgery. What about the anatomy of the shoulder? I'm just going to make it reverse it back. because now I'm just going to speak about the shoulder injection. So the anatomy of the shoulder is a not one shoulder, it is 4 shoulders. For a joint, and this joint is attached by muscles to fix it, and ligament and tendons. And the main nerve supply, they have main nerve supply is suprascapular nerve and axillary nerve, but in some cases they have many other nerve like lateral pectoral nerve, like what's called an longitudinal nerve, give a contribution. This is just to show the muscle of the back and how it fixes the joint, and to see the bone of the joint like humerus, scapula, clavicle, sternoclavicular, and the AC joint. And another picture, you must remember that there is a variation in everything about the joint, variation in nerve supply or muscles. And this is what's called the rotator cuff tear. Rotator cuff muscle is a 4 muscle. It is a subscapularis, supraspinatus, and infrascapularis, and teres minor. And this muscle fixes the joint, fixes the head of humerus to the joint. And all this muscle, I can appreciate it in the ultrasound and can see any pathology in this muscle. And before I forget to tell you that there is many ligament to fix the joint. Nerve supply of the joint, I just will go suprascapular, you know it, in regional anesthesia, because they have a contribution in management of pain. And a small word to say about suprascapular, usually we make it whatever there is an compression or not. Most of the study, new study showing that if you close the outflow of pain, not just to inject the bursa or muscle, if you inject the nerve, first thing you can get a benefit that it helps you to make another injection without severe pain. Second thing about the suprascapular, this is the main outflow for the brain. So if you close the main outflow of the brain, you make a switch off for the brain and increase the time of relief of pain, even with local anesthesia only. And this is how to make it in the supraspinatus fossa. And there is an suprascapular anterior approach, but really we don't use it because in chronic pain, because you need to go for the area of entrapment of the maximum outflow for the suprascapular nerve. There is other technique, posteriorly to suprascapular spinal glenoid fossa, but if the patient have a pain in AC joint, acromioclavicular joint, he will not relieve because when you inject the nerve in this area, he already gives the sensation for AC joint. The other one is axillary. I will not speak a lot about it, but it's about 20-25% of the pain came from axillary nerve. And this is how to see the muscle in bursa. The shoulder is full of bursa here, and this is one bursa. Sorry. This is a bursa, and you can see what's called rotator cuff interval. This interval I can inject it anteriorly or posteriorly from for the nerve, and this is the AC joint, acromioclavicular joint. Now, just to go into how to examine the shoulder, I want to see the pathology. First of all, if you put the probe like a cross-sectional like this, you can see the supraspinatus and deltoid muscle. I can show for you the supraspinatus and the long head of biceps. This is the main tendon inside the joint, and head of humerus, as I appreciated here, and subscapularis tendon and deltoid muscle, which covers all. Again, if you look for longitudinal, because sometimes you need to see the fluids, you need to see the calcification. So what is the pathology which I can see? If I see the structure is thickened, or have a fluid around, just like edema, or have a calcification, or I can see the tear with dynamic action. When I make a dynamic action, I can see the tear. Now it is a muscle, I look longitudinal, what I appreciate, long head of biceps, this is the same, but longitudinal, the deltoid muscle, and humeral head. Here you can see, if I go a little lower down, I can see more muscle here. Appreciated muscle, subscapularis tendon. Subscapularis tendon like a 3 tendon. Sometimes you see like a tendinosis, but not a tendinosis. It's a normal to feel like 3 tendons. I see that is deltoid biceps and humeral head. Here also, if I go for like, for example, put the acromion, this is acromion bone, I can see anything under the bone. And this is supraspinatus tendon, like a parrot beak. This is the head of humerus, supraspinatus tendon, and this is what's called subacromion subdeltoid bursa. Usually, you don't see anything here, but if you see the fluid, this is means bursitis, or just a subacromion subdeltoid bursal collection, and you can see that if you have a supraspinatus tendinosis or tear, and this is acromion. Again, if there is many view, And this is about 12 structure you can see by ultrasound. So this is just for examination. I don't speak about management now, but in the same time, you can manage all this structure by injection or by radio frequency or by what's called calcification. You make what's called the fenestration for the tendon, or just to make a breaking barbotage for this calcification. So I show you that some the same again, supraspinatus, baroid and deltoid and humeral head. And this is from behind. You can see it appreciate the head of humerus, and this white black stuff. Most of people can interpret it as a fluid. It's not a fluid because it's regular. This is a cartilage, and this is the site of injection intraarticular. You know, and if you look for the structure here, if you look for the structure here, you appreciate it, deltoid muscle. If you go down, the teres minor muscle, and this is a joint capsule, but don't inject inside the cartilage because you can affecting the joint stability or joint in health. So here, if you're looking here, this bone and bone, all the joint is the same in the body. It's like a V-shaped structure, you see there. But if you look here, you can find this is a ligament, and this is a fluids, and this is an AC joint. Capsule and the clavicle. So I will not speak about it, but you know this gentleman running, riding and camel beside the bear, and this is not me. So again, if you look for the structure, anatomy, and ultrasound, the same. Long rod of biceps sheath, subscapularis, and if you, in some view, you can bring in what's called an supraspinatus. So here you're looking usually. There is an artery, it's called anterior circumflex artery. You can see here all the time, this artery. When you go to inject, take care about this artery. Because if you make a hematoma, it will be, here you can see many muscles, supraspinatus in the view, just to make it tilting the probe only. And see subscapularis, long head of biceps, and you have here, this is your target because there is some fluid in this star. Again, when you go for a rotator cuff interval, you have many views to see a different structure. And with this different structure, even with sleeping like this, you can see the joint from behind. And this is infraspinatus. That's if you puncture infraspinatus, go to the joint. This is clinically speaking, you are in the joint. So all the time, just to give you some clue about what's the probe to use and how to examine, what is the dynamic action to examine. And this is some picture from a pathology. You can see here, subdeltoid fat, you can see some fluids here, and this is expressing. But don't think that all the pathology you see can produce pain. In many patients, I found a very big bursa without pain. Don't touch the patient. But if you found even a small collection of severe pain, you can go for just intervention. And here you see the clavicle, acromion, and the disc in between. So what is the ultrasound finding in pathology? As I told you, fluid around, fluid is not present in a normal place because the bursa usually like a thin film. Hypertrophy, found the structure hypertrophy, for example, like an piriformis, one of the diagnostic problem to find that to compare between the two, and you found that hypertrophy. And for example, also if you found lateral cutaneous nerve of the thigh in some study, if it's 1.6 from the other one, this means the diagnostic for Marassia parasitica. Increase the vascularity if you have an acute stage, increase tissue, fibrous tissue, and calcification. You can see here, you see the calcification. This is the AC joint, and this is a very big calcification inside the joint. So they started by fibrosis and calcification. So just to make a barbotaging for this calcification, and the patient improve a lot. I have patient with an tendo Achilles, like calcification everywhere. Calcification was a football player and retired, and he can't walk. And I make him like a fenestration or destruction for this under local anesthesia for the calcification, and improve now about 6 months. Here to show some pathology. If you have a fluid, as I told you, this is fluid around biceps, and to go for injection here, whatever you inject, local anesthesia, corticosteroid, also BRB, polarotherapy is the same. Here you see also the fluid around the biceps, and also there is no concavity here above this the bone. It's called subluxation, and when you make a dynamic picture, you found this tendon coming out. So here, how to inject from medial lateral, lateral medial, in plane or out of plane. But my advice, don't to go out of plane because it needs an engineer more than a physician. It will be very difficult. You need first, when you build your career, to make your injection in plane. And here also, if you go for the joint space, here's the joint space, but don't to go for the structure, for the cartilage here, and you can inject here. Also, this you can see how big this subacromial subdeltoid bursa, this deltoid, supraspinatus, and here's a cartilage, and here's the fluids. And these fluids can make an ballotment, like an what's called dynamic mixture. When you're moving the compress, you found this fluid coming and increasing and decreasing also. Here also, you can just go for acromioclavicular joint. You can see some fluids here, tension. This is supraspinatus down, and this clavicle acromion. And if you ask me about this one, I don't know. I will tell you I don't know this joint because all the joint is the same. You must give me this picture to know this is the AC joint. And here again, you can see some calcification ossifies around it. So at the end, shoulder pain is one of the most problematic thing. I know that it takes more than time, but to diagnose and to make an injection for the joint is a very important tool. And also sometimes we make a radio frequency, whatever the medication. Sometimes we can electrical treatment like peripheral nerve stimulation with the suprascapular, or just to make a radio frequency for the nerve. But at the end, it's very common and have a treatment. And if you make an injection and physiotherapy, and most of the patients send it for physiotherapy before injection, he can't to continue the physiotherapy because the physiotherapy increases the pain. But after injection, he can get a good result, and we have hundreds of patients improving for many years, and sometimes coming back when the pain return about 50%, and they need another injection. And even the patient requests injection, I will not take an medication because medication harden my kidney and my livers, and I have a side effect from this medication. I know that time is not over, but at the end, if anyone just get a shoulder pain, he become like this middle one, he can't use the other hand, and get a fibrosis and affecting quality of life, sleeping. And the most important thing about the pain in shoulder, most of the patients tell you, I can't sleep on this side. And this is what's called a diagnostic to differentiate between neck pain, radicular pain, and the shoulder pain. So my sweet conclusion that we are in 2022, and the research is running all the time to see what is the ideal for shoulder pain, and many study every year for coming for that, because the new era of ultrasound to treat and to diagnose. But shoulder pain is common, it's very common. And even many of our colleagues tell me shoulder pain as a chronic pain is very common. History and physical examination is paramount for diagnosis. Conservative management is a cornerstone. More than 60% or 70% of the case can be improved completely by a conservative method if it treated early and not ignored. Intervention management come to fill the gap between the medication and the operation. So we have a medication, intervention, pain management, and operation. Ultrasound diagnosis and intervention is now become have a great role in diagnosis and intervention. For me, I make an ultrasound for all my patients in my clinic if I found a pathology, and this pathology producing a pain, I just targeting this pathology. Sorry. Need a very long journey of training. You know, when I started this career, I found it very difficult, but now I have a plan in my brain how to diagnose, how you see it. And the more you see, the more you learn. The more you do, the more you become a professional. And patient selection is very important. Don't go to inject a patient have a pain with an infection shoulder, for example. And to know the indication and the contraindication, your capability, your hospital facility, safety paramount, and believe in yourself all the time. If you are a cat, you can see yourself as a lion. And you must know that life don't get better by chance, it get better by chance. Thank you very much for your attending, and really for any question. And sorry for taking more time. It's okay.
اتفضل دكتور هيثم. اتفضل.
اتفضلي يا دكتورة صفاء.
الحقيقه يعني very fascinating and informative lecture، وحضرتك عملت لها ستريمينج بصراحه بشكل رائع وجميل وكونسايزد to the point. تقريبا احنا بدأنا حوالي 50 people attending، ما فيش حد leaving the lecture at any time. يعني وده يعني شهادة يعني راجحة ان احنا كنا in an amazing lecture. ربنا يكرم حضرتك يا دكتور ياسر ويكرمك يا رب بكل الخير. شكرا لحضرتك، محاضرة رائعة الحقيقة يعني. اتفضل حضرتك يا دكتور هيثم.
Thank you, Dr. Safa, for to be honest, it's hard actually to have a blink of eye or have a glance away from the presentation. It's very informative, very comprehensive. I would say that actually deserves to be a symposium, not only a simple lecture, to be honest, because it's full of very impressive, very exciting lecture about one of the main complaint, or because as Dr. Yasser mentioned, plenty of our colleagues actually having the same complaint, including me, by the way. So I think it's mainly related to the stress of work, the posture, the psychology, and it was very interesting actually to explore those elements that might really precipitate, rather than focusing more about the functional or the physical part or the physical aspect of diagnosis, which is actually, thank you, Dr. Yasser, for that really impressive and very, very nice and very exciting presentation. And I'm not surprised as well, Dr. Yasser keep on telling information that it's been mixed and due with a kind of a very nice, very simple slides that actually helps to keep everyone actually very, all the attendees are very, very, keeping all in a very interesting level of knowledgement. I have question, and I'm not sure we can just also take some questions from the floor as well. But I mean, I have a question here about when you mentioned about the psychology. Do you think that the stress itself could be treated along with the physical or the pharmacological? And I agree with you definitely, because most 60% of those shoulder pain could be treated effectively and efficiently by the conservative treatment. But do you think that we should refer those patients to psychologists, or how can we give them a support? How can we give them a kind of psychological support in order to sort out the problem?
Really, I'm just not to go in details, but the most effective clinic with pain management is called multidisciplinary pain clinic, and mostly use about 5 physicians and sometimes 6 physicians. As I speak on, and I said in the presentation, you must have a psychotherapist, what's called specialized in pain medicine, psychotherapist working for pain medicine, and physical therapist, and even social therapy. Social therapy sometimes will give the patient some compensation, some money. Social therapy just give him tools to help him, like a stock or wheelchair or something like this. So the most effective is multidisciplinary pain management, as I told you, and psychology is a very important issue. Some patient, even I can't make injection with psychological problem. Whatever you did for him, he will not relieve. But if the patient coping and know that and go for, that the first visit must be really for the psychiatrist, because he discovers the pain gainer, the patient who's gained by his pain, and pain related to psychological problem, and even psychogenic pain, as I told you about the lady. So those people just need a psychological support. And many patients for my clinic, when I send for psychological support, he come and improve and he understand everything, because the best speaker is a psychotherapist. When I speak to him, he just know the bottom of his thinking and intention and everything. So you can't make a pain surface without psychotherapy, without physiotherapy, without social therapy. Even sometimes we need a surgeon, because my head in Saudi Arabia was in the head of pain unit was an spine surgeon, and was very interested. So we need the help of all this specialty. I think I put a picture here, and I put a picture that a very important picture about who's treating the pain, So for acute pain, it can be treated by I'm just a head of recovery. It's treated by my resident, by anyone. But for chronic pain, the problem, it must be a multidisciplinary team just to treat the patient. You can't make it by one physician only. So psychotherapy is very important. Physiotherapy is very important. Without this, you don't get any result. And in some disease, for example, I tell you about myofascial pain in the back or piriformis. If you make injection is not the treatment. Injection just to relieve the treatment for 1 week for stretching exercise. The treatment is stretching exercise. But the patient can't make the stretching exercise without treatment of pain first. And sometimes the management is not your job, just helping and just to relieve the pain.
Good. I have another question also, Dr. Yasser, about the type of medicine that will be injected in the bursa or in the shoulder. Do you consider also injecting steroids along with the common injection of local anesthetics as well?
The problem with the steroid, we don't have a very great evidence just for injection, but most of the physicians, even now, I found all the physicians all over the world use it, and I use it, but I don't use it more than 1 time or 2 times maximum in 6 months. Because if I need another thing, I need BRB or just because you know what happens if you inject a steroid all the time, you get softening of the tendon. You can get many problems, infection, skin, fat degradation, and all this stuff. But in diagnostic test, most of the physicians, even without high evidence, because they don't have a great evidence in all the pain, just to inject, I injected once if I need more than 6 months. But if the patient need anything, I have another option, Polaris therapy, like glucose 15 to 25% and give a good result, or just to give BRB or super BRB or all these medications.
That's good. And I think this is very supportive as well. For the last, couple of days ago, there is a very interesting report that's been published by BMG in UK and Ireland as well, about the use of the steroids has been accompanied by kind of the occurrence of fibrous tissue development in the body. Not only in the local by local injection, but even whenever being used as a systematic as well. And that definitely actually supports your idea about the steroids. Actually, should never be used for more than 1 time or for the single injection as well. I agree with you.
Yes.
So that's very interesting. But what about the use of non-steroids as a pain, and along with the gabapentin and other things? And forgive me for my illiteracy. I'm not really that very expert about the combination of the medication being used for pharmacological treatment. So, but do you think that as long as we are always focusing on the conservative treatment, this means that we need to relieve the pain? So many clinicians, and to avoid the opioids, they go with the non-steroid, the mixture of non-steroidal and the gabapentins and pregabalin and other mixtures. Do you think that it might really give a very good outcome before we think about the injection?
The conservative is a many steps. You don't rely on medication only, but in many cases they started non-steroidal anti-inflammatory is a very good drug. Paracetamol in some cases can work. Also muscle relaxant, whatever the degree, for like an Muscadol or paracetamol with orphanone, or just tizanidine, which is Sertraline, and even baclofen, it can work good. And also the ointment, or just if you have non-steroidal ointment or hot fomentation, or just a stretching exercise. Usually I start like this. If the patient don't have a neuropathic element, no needs for pregabalin or gabapentin. But in some cases, the patient maybe have an irritation for the suprascapular nerve and have what's called neuropathic element, not just a nociceptive element. Many times you can get a patient with mixed type of pain. So gabapentin can work with this patient. But really, before to go gabapentin and pregabalin, if the patient not resolved the pain, just to go for injection, at least for diagnostic injection. And about 80-90% of the patient improve a lot. I have a patient came to my clinic in Wednesday. 2 patients, I make injection 2 years ago, and he come for follow-up. And one tell me that her pain return for 1 month now, about 50%, the other 30%. Do we need an injection? I tell him, no, not now. And one of them is a teacher, and the other one is an engineer. But in many cases, you don't go for higher up. And I have a patient is an head of MS here. He was serving a patient by ambulance, and the car come to crashing him during his duty. And I think his grandpa was the president of America, one of the president, and he suffered a lot and now make many operation his shoulder, and now living in Macedon.
Yeah.
Oh,
Yes,
So
sorry
she's
for
a chronic pain
interruption,
submission. Yeah.
Dr. Haytham, sorry for interruption. I
No.
suppose that the patient age, sex, occupation, and the comorbidities will influence the combination of drugs. Okay?
Definitely.
Am I
yes.
right?
Yeah, definitely, yes. It should be considered. This is one
Yes,
of the
should
highest
be
considered
considered.
points. Yeah,
The
definitely. Yes.
combination of the drug used.
So, you're right.
Dr.
You're right.
Yasser, for how long I can use the combination of drugs, non-steroidal or paramol or other drugs? For how long?
You know that
Shift
there
to
is no
another step.
guideline. There is no guideline. There is a guideline, for example, for back pain. If you have if you have a specific back pain, the American Society of Spine Surgeon given you 3 to 6 weeks, use a medication. If not resolve it, just go for investigation, go for but really you don't have an such a strong guideline for shoulder pain. But if you use it, because some patient, as I told you, not durable with medication. He don't like medication, he take a medication, he get a side effect or get stomach pain. So he come to ask for injection.
Yes.
And also, if you have a side effect, if you take it for a long time and you have a side effect, you must search for injection. One injection can help you, and physiotherapy can help you a lot. So if you got a side effect of medication, if you get it for a long time and you're scared about renal function coming up and liver function coming up, so injection maybe, and you know, the old people scared from a needle, but it's under local anesthesia. And like we said, شكت فوته لحد يموت. Then I say for my patient like this. So many factors affecting that. If you have other comorbidity, you have a heart problem, kidney problem, liver problem, usually we don't like to give non-steroidal for a long time, especially the non-specific one. We have non-steroidal three category. Non-specific COX 1 and 2, like Brufen, like all this stuff. We don't like to use it in chronic base. And we have a preferential like lorinoxicam or Bleloxicam, like Zifo, what we know it. This is an less side effect, less potency, and the COX-2 inhibitor, what we found in the market, like celecoxib, bellocoxib, etocoxib. All this medication can be used for a longer time, but they have also a problem or side effect. So if we're going for chronicity, we're looking for a safe drug. If you're looking for acute case, you can take whatever you want. So for chronic, use the less side effect, maybe not the potent one. And also medication alone can't help you. It must be making like physiotherapy, stretching exercise. Because if you're scared, that's called fearing disability. If you're scared to moving your shoulder because of pain, at the end it will be fibrosis and it will be malfunctioning.
That's lovely. Dr. Safa, are you planning to get this topic to be as a hot topic, as one of the MD exam questions?
No, I'm not responsible for the question. No, I'm not the head of the department. I'm just one professor among many great professors.
No, because it's very interesting, to be honest. And I have just to expose our junior colleagues as well, or our dear residents and lecturer there in the university as well. Dr. Yasser mentioned really a very interesting point here when he talked about how it looks like when you put the probe on the shoulder, and he said that the bursa could. When you use the probe, you can check if there is a fluid around the capsule, which should be that it should never exist. And he mentioned that we can even diagnose the fibrous tissue, which is very well understood as well. But how Dr. Yasser, you can check if the patient have a high vascularity or not with the ultrasound probe? This is for my own interest. It's very interesting for me as well.
Yeah, in acute cases, when you have a very vigorous inflammation, usually vasodilatation happen in this area. And you know that in traumatic or just inflammatory cases, if you put the probe and put a color Doppler, you found all the area pulsating, you know. But this unfortunately not happening in chronic case, because in chronic case, it may be fibrosis, endarthritis, and also calcification.
Yeah.
We see a lot of calcification, we see a lot of fibrosis, you know, because what happened when you get a problem in the body? Usually you have a tear and wear all the time for your muscle, for your skin, for everything. But if the tear become more than the wear, you have a problem. And what happened during inflammation? During inflammation, there is a cycle to happen. Injury, inflammation, and regeneration and remodeling at the end. If the cycle not going like this, you have a problem. For example, for our management, sometimes I have a tendon which is calcified and have a severe pain. What I do in this tendon, I just go by a needle, was called under local fenestration. But needle make a fenestration in the tendon. What I do in the tendon, I make a vigorous inflammation again. So this inflammation promotes the regeneration, promotes the healing, and promote the remodeling. And this is one of the modalities of management. And this is one of the modalities of management how to treat. So inflammation is acute, fibrosis, calcification, and you can discover all this stuff by ultrasound, and can see if you have a ligament tear, partial tear, complete tear by ultrasound. When you're moving the shoulder, you found the tear become like an this Popeye, for example, biceps like Popeye muscles, have a very big muscles if you have a tear. That's okay. I hope to answer your question.
Yeah, that's excellent. Thank you so much. Thank you so much. Dr. Safa, do you have any questions?
Anyone of the floor? Anyone of the floor?
We can take some questions from the floor as well.
Yeah, someone asked a question, but really it disappeared now. Nearly the posterior approach
for any question of chronic pain as a global and also in shoulder pain, because they're very common. The most common one is back pain, and I have a presentation later, inshallah, because most of us have back pain in any time of his life, and he need to know the type of character of the pain and how to care about it, what's the red flag. So, but now anyone just want to ask about chronic shoulder pain, because I make a presentation about regional anesthesia. It was very interesting for the people, but really it is very important now because our scope become expanded a lot.
Anyone have a question? Anyone have a question?
Assalamu alaikum.
Wa alaikum assalam. Wissam. Dr. Yasser, this is Wissam Sultan, is the assistant professor of anesthesia.
My colleague. Dr. Wissam, نار على
العالم. Dr. Yasser, thank you for your informative lecture. It's very nice and amazing. Actually, it's a basic question, maybe. How could we differentiate between the pain originating from the shoulder itself or referred pain from radiculopathy, cervical, or whatever? It's just by physical examination, imaging, or there is a specific way to diagnose?
I always start from the history. And the history is, I've been tell you, I can sleep. For example, radicular pain, he sleep very good. He don't have any problem with sleeping. And the patient can sleep in that side easily. But in shoulder pain, he can't sleep in the side because the muscular pain is more severe than the nerve pain. This is against what we believe. So the first one. Second one, if you go for MRI, it's not conclusive. Usually I use it to exclude. But sometimes you have a disc. Most of the people have a disc prolapse. You know that we have about 30% of the people have the disc, but mostly don't produce any pain. So this is misleading. Third thing about the character of pain. Character of pain, usually radicular for the neck, radiating from the neck to the hand, and sometimes giving you, according to distribution, little finger, middle finger, or whatever the fingers. So this is the second thing. For shoulder pain, usually neuropathic, nociceptive, just like a pain of trauma or surgery. And second thing, if you have some pain, neuropathic can come from the irritation for suprascapular or dorsal subscapular nerve in the back, and you found a small area for neuropathic pain only. Third thing, if you make an examination for the shoulder, you found a pathology. Mostly you found a pathology. But with CT or MRI for the shoulder, you can find the pathology. So this is more coming to the because I have this is a problem with the surgeon all the time. When patient have a shoulder pain or root of the neck pain and make an MRI, found the pathology, this is an radicular pain. Even the character is different. But one of the most important thing, if you ask the patient, can you sleep in this side, in the side of pain? If he tell you, yes, I don't have a problem, this is not a shoulder pain.
Very nice. Very nice.
Yeah, it's very nice, Dr. Yasser. So what about the pharmacological management for both? Is it almost the same?
If
or
you have a
different?
nociceptive pain, yes, nociceptive pain mostly respond to simple medication like non-steroidal inflammatory, paracetamol, muscle relaxant can respond very good for this medication. But for neuropathic pain, you need a neuropathic drug like an selective serotonin uptake inhibitor like duloxetine, fluoxetine. You need an gabapentinoids that like pregabalin or gabapentin. Yes, but the most common drug is use gabapentinoid because the lower side effect. I have a presentation. I was searching against what I know that duloxetine, which is Cymbalta, have a good evidence more than gabapentinoid in back pain, and we use it now. And we see some results because we know have an controlled drug, gabapentin and pregabalin, but fluoxetine, duloxetine is not don't have this what's called an prescribed medication. So
but I
it
think
works
it
very
has,
good in some patients.
Yeah, but I think it has a psychiatric problem sometimes with Cymbalta.
All this medication can be reduced side effect, you know. Also, gabapentinoid can do this effect, but you know the less side effect, as I told you, gabapentinoid less than side effect from the other medication.
Good. I have a question. Oh, thank you so much. I have a question here from the floor from Dr. Fatma Adil asking about the best approach for needle visualization in posterior approach in the supraclavicular nerve block. And she thanks you in advance.
She's asking about how to make it posterior approach.
Yeah, the best approach for needle visualization in posterior approach of suprascapular nerve block.
Yeah. I'm just to give her the picture. You know, this is my picture and my presentation. You know that the suprascapular coming from the notch of the scapula here and coming back with the suprascapular artery, and here is spinoglynoid fossa, and ramified to supply all this area. So I can make it what's called a superior approach to hit here in this what's called the spawn sign, or just to attack here posteriorly, because sometimes I don't see the nerve here. It may be going through the bone. It may be absent from this area, so I can't make attacking here. But if I attack the nerve in this area, if I injected a bit nerve in this area, already the branch for AC joint is not is passed, so you can't get a relief here in this joint. And here also, this is the spine of the scapula. This is the normal. This is what we did on all the time. Here, this is a ligament, and this is a artery, sorry, nerve, and this artery inside and outside. And there is an anterior approach, and this is a posterior approach. When I don't see the artery, the classic is a superior approach. But if you don't see anything, you can just go a little posteriorly. You can find the head of here, the head of humerus, and here was called spinoglynoid nodes, and you can inject it here. I hope to answer your question.
Yeah, that's perfect. And another question as well. I go just a rush with the more question here about the pain is considered as a protective mechanism. Is there a risk of we kill the pain by the intervention from this point of view? For example, genicular nerve plane, can it make it the patient over the use of his joint and worsen the arthritis degeneration? I mean, I think it's a matter of if you think that the pain, if we kill the pain, and I think it's relying on one of the latest reports as well, that the pain is protective. So killing the pain might really cause more damage in the long run, and especially with the intervention. What do you think about that, Dr. Yasser?
You know that that's what I'm telling you, that not all the sign, this is a logic. What you see now is logic, but not all the sign is logic, and not all the logic is science. So what happened already, if you have an osteoarthritis, they found in the study, if you're using this joint, but not overuse, if you're using for walking and even swimming, and use this joint, but not overusing, this is improve the function capability, improving everything. You know, the pain, relieving of pain is a protective, not against what you said. What you said is logic, but this will not happen in reality. You know, if you use the joint, this is what's called give you that what's called tonic action for the cartilage, for the muscle, for everything. So relieving of pain, as you said, is not make an function disability after that, or can you use a joint in a bad way? Because the pain doing that, the pain If you lift the pain, it can do everything in your joint and your muscle. But if you use it in a normal use, not an overuse, all the studies showing that improves the function, capabilities, and no hazards from that. I agree with you that, as you said, this is a logic, but not science. Science say against that. If you use it more, but not overuse, you improve the function and improve everything.
Good, and I think more questions from the floor as well from Dr. Ahmed Haggag asking about the frozen shoulder. Do you think that what is the best intervention? Does the supraclavicular is more than enough, or you think that we have further intervention to be done?
You know that frozen shoulder, you need just to relieve all this fibrosis or adhesion. So usually you make it with the surgeon, make it just general under anesthesia to make an over movement to cut this fibrosis, but the patient coming screaming like crazy after operation. Mm-hmm. So in many cases we did an suprascapular and axillary, and we give the patient some sedation. It worked very good, and even for post-operative. And there is many studies about showing to inject inside the joint, even to rupture the joint. To inject it at high volume, even to rupture this stuck the joint. So suprascapular working good, axillary with axillary, or just to make local injection inside. But most of the time, as this is a new era, just suprascapular block or axillary block is the main outflow for chronicity. So you must stop it, because you make a switch off and switch on. Like if you have a computer, for example, and you have many problems, what is the first thing you do? You close it and open it, and usually working. And this is what happens when you do anything with the shoulder, you're injecting an suprascapular or axillary. But you can inject suprascapular axillary, it's working very good, intraoperative, post-operative, and also what's called injecting the joint itself.
Excellent. It seems that the discussion with you is opening too much queries here. I have another query from Dr. Muhammad Arshad asking about the role of radiofrequency ablation.
Dr. Muhammad Arshad is our colleague here, specialist in pain medicine. And I make injection. I make injection of one of your limbs. You know that radiofrequency have a role, because as I told you, first we do a diagnostic block. This diagnostic block may be prognostic also, or maybe curative also, because sometimes when you can make a diagnostic block, and it can stay for 10 months or 9 months or 2 years. So I don't do anything more. But if I make an injection, as the patient live for a few weeks, 3 weeks, 4 weeks, was good, but the pain coming again, I'm thinking seriously to make a pulse radiofrequency for the suprascapular, and we'll make many cases suprascapular and axillary pulse radiofrequency, and the patient get a very good improvement. Although just to make a shoulder joint, what's called genicular nerve, it can give a good result. So the first injection just for diagnosis. If it stay forward for a long time, this means diagnostic, prognostic treatment. But if the pain come very fast, and for this for diagnostic, I just change for radiofrequency. Mostly of the management of everything to make a medication, after medication, electricity. After electricity is the surgery. So it can have a role here if the pain came very fast after injection.
Oh, excellent, Dr. Yasser. Thank you so much for a very, very comprehensive answer. Another question, your approach to the axillary nerve block from Dr. Muhammad Ahmed.
Yeah, axillary nerve block, this I will show the picture. I just usually coming from behind the humerus here. Here, this is acromion. If you put the upper part for acromion, and you know that you put the problem longitudinal, you can found like this here. You see this picture. This picture is called the orienting structure is the artery. You found the artery here pulsating, axillary artery, and you know that you found the axillary is near here. But most of the time you don't see it, so you can make just infiltration around the artery. But also I can make it transverse, you know, the axillary artery, the nerve like this. So this is a humerus. It's the same like an radial artery, but the radial artery is lower down under the fascia. But here, if you put the probe transverse, or just a little oblique, and to searching for the artery here. So this is a bone, the humerus, this is the artery, and this is a nerve beside. So you can make it what's called transverse approach or just longitudinal approach. And there is, I know that there is an anterior approach. I hear that from Renhard Mogli, but I don't see the paper. He published a new stuff about to make it anteriorly.
Excellent. And I think it's I have an input from Dr. Ahmed Haggag as well. He's speaking about the range of movement. It might really be improved with the use of axillary, and I think he will endeavor using the axillary also. I think it's that's actually arose a kind of a question about the range of movements. I mean, with the axillary approach, do you think that the axillary approach what helps actually to improve the range of movement rather than the other approaches?
Axillary only alone without suprascapular?
Yes.
Suprascapular supplying from literature about 60 to 80% of the joint, and axillary just confirmed about 20 to 40% of or 30% of the supply. But you must know that in some cases, even lateral pectoral can work, longitudinal can work, dorsal scapular and nerve to subclavius can work. You know, because you know that as a Hilton rolls, any nerve passing the joint and is still valid. Give a branch to this joint. So what I'm speaking about, the major contribution for the shoulder is axillary, suprascapular, then axillary, but there is other nerves. And because of that, if you mix the two nerve, suppose for the patient to go for surgery, most of the time he can't make a surgery without infiltration of the surgeon with local anesthesia, because maybe in some patient other contribution were. And there is a cadaver study about that. Anyone just needed, I will just send it to him.
I think I have a hand up from Yasser's iPhone. I mean,
this
yeah,
is your phone, Dr. Yasser.
One hand up here.
This is your phone, Dr. Yasser.
Yes, hello.
Hello.
This is Dr. Yasser. I'm calling from Qatar. I'm a consultant in pain and anesthesia in Hamad Medical Corporation. Dr. Yasser is our senior and our teacher. First of all, I would like to thank you all for this nice presentation and arrangement. It was really amazing. And it's a simple question regarding the anterior approach for the suprascapular. With this advancing technology, do you think, Dr. Yasser, that we are going to shift from the posterior approach to the anterior regarding the smaller dose that we use in the anterior approach? Thank you very much.
You're welcome. Thank you, Yasser. Yasser was my fellow and one of the most eminent and professional one, and now is my colleague. I was very active, and you know,
welcome.
And he was one of the most professional.
Welcome.
You're welcome, Dr. Yasser. Nice to meet you.
Welcome.
His name is Yasser al-Tayyib, and he's a very tayyib, very kind, and all people coming to asking for him and asking me, are you Dr. Yasser al-Tayyib? I tell him no. There is Yasser al-Tayyib and Yasser al-Tayyib. I am not. So anterior approach is a problem with pain management. We don't treat like a regional anesthesia. The regional anesthesia, if you go for any part, for example, if I give you for carpal tunnel syndrome, if you go for any part of the nerve, you can get some relief for the pain, but at the end you need to injection for the interrupt area, for the area around the irritation. So I think in anterior approach is a very good approach, but for regional anesthesia. But most of the literature don't speak about it in pain management. In pain management, and as you know, yes, we just want to go for examining the nerve for entrapment syndrome. I examine the nerve cross-sectional and longitudinal, and I see the area of edema, the area of increased size, and this is the area you inject during the injection. So up till now, we don't have enough study about it. We have enough study about that low volume and very good in pain management for surgery, but for chronic pain, we don't have such an evidence that it works good, because we need to inject the area of entrapment, not the area far away from entrapment. And I hope you agree with me for the.
Perfect. Thank you, Dr. Yasser. And I have another hand up as well from Dr. Ahmed Haggag, but he lowers his hand, and I'm not sure if he still wants to speak. Dr. Ahmed Haggag.
Ahmed Haggag.
Hello, how are you, Dr. Safa? How are you, Dr. Haytham? How are you, Dr. Yasser?
Fine.
Thanks. About my question, I mean that suprascapular I have used a lot. It improve range of movement and relieve 60% of pain. I think it is enough, but after Dr. Yasser tell me about auxiliary, so I will try it. it is the first time for me to come to make two blocks for relief frozen shoulder. So I want to thank him. Just thanks for for this lecture. It is very, very excellent, and thanks for you for your lecture. Thanks.
Thank you, thank you.
Very welcome. I have a legacy hand, I think, from Dr. Yasser's iPhone from Qatar. You still need to speak, Dr. Yasser, or this is a legacy hand?
No, I think I did not get it down. I will get it down now. Sorry.
Yeah, no bother at all. Take your time. Yeah.
Thank you.
You are Yasser Tayyib anyway, as Dr. Yasser has been, so you can keep the hands up anyway. No problem at all for us. we need too many hands up anyway from everywhere. Because to be honest, actually, personally, I was really very delighted actually to attend this lecture, not as a moderator, but as a learner. I enjoyed, and I learned, and also I was very interested from the very, very early beginning till the very very late end. And I actually addressed down many points as well that actually helps me actually to understand more about the shoulder pain and to understand about the recent advances in the treatment and the management as well. And I would say that actually everybody was enjoyed that kind of presentation. And it goes without saying that Dr. Yasser actually makes the thing here, makes the whole presentation very easy, very simple, and very interesting as well, and enrich our knowledge about all the data about the shoulder pain, about the management. Whether you are interested in the pain management, interested in the shoulder, or even if you are attending like me, as a part of your interest about the shoulder pain, how you can manage that, and it's a very common problem that has been faced for all of us. I'm not surprised that Dr. Yasser actually encouraged us to ask him for more contributions in the field of regional anesthesia in order to enrich our knowledge and enrich our exposure to this very, very interesting territory of his experience. And I would like at the end, as long as I don't have any questions from the floor, I think everybody is satisfied. Everybody has been engaged in a way or another. And I will thank you, Dr. Yasser, for your very informative, very comprehensive presentation, very interesting streaming of the whole data. It's never been boring at all. It was very interesting from the very early beginning until the end. I would like also to appreciate and really highlight and really thank Dr. Safa for being an engine and the initiator, the one who actually has been standing behind all of these arrangements. Thank you for your invitation, and I will over to you, Dr. Safa.
هتكلم عربي بقى بعد إذن حضرتك دكتور هيثم.
اتفضلي.
طبعا يعني الدكتور ياسر كان النهارده يعني عازفا محلقا، وقال محاضره الحقيقه انا بعتبرها ريفرنس، ومحدش فينا يدور على حته ثانيه يقراها منها ان شاء الله، وهي ريكوردد وانا هنزلها باذن الله، هتنزل على الجروب بتاع الجروينج انستيسيولوجيست. ودكتور ياسر انا بصراحه ما عنديش كلام اقول لحضرتك ان دي من احسن واعظم المرات اللي انا سمعت فيها محاضرات، والله العظيم ربنا شهيد. فربنا يكرمك بالصحه والعافيه وطول العمر. طبعا انا طبعا مش بحرج حضرتك، لكن انا على الهواء مباشره عايزه اخد وعد من حضرتك انك تقول لنا رول اوف الترا ساوند ان اير واي مانجمنت اللي حضرتك قلتها في مؤتمر قطر. انا ما بحرجش حضرتك ولا حاجه، بس الدكتور هيثم بيقول لك مور كونتريبيوشن.
طلباتك اوامر. لا طلباتك اوامر ان شاء الله يا دكتوره صفاء.
دكتور هيثم
لكم احسن من المؤتمر، لان المؤتمر فيه ريستريكتد تايم بس.
الدكتور
المؤتمر بيبقى فيه 25 دقيقه بس، فكان ريستريكتد تايم، بس ممكن نقولها لكم احسن من كده.
هتكبرها يعني. دكتور هيثم الدكتور ياسر بصراحه عمل محاضره على الاير واي، على الرول اوف الترا ساوند في الاير واي مانجمنت في المؤتمر بتاع قطر، كانت رائعه، وحضرتك هتستمتع برضو زي ما استمتعت النهارده. فاحنا على الهواء بندعوه انه يحدد لنا اي جمعه واحنا موجودين، احنا مش هنروح في حته، احنا
انا
هنستنى.
موجود اي جمعه انتوا تفضلوها، انا ما عنديش مشكله يا دكتوره صفاء.
ربنا يخليك.
وفي بعض
دكتور
الاخوه
هيثم،
برضو بعتوا لي من عندكم عاوزين اللو باك بين،
والله
فممكن نعملها برضو. انا تحت امرك في اي وقت،
ربنا
يعني تحت امرك
يخليك،
في اي وقت.
ربنا يكبر خاطر
الله
حضرتك. دكتور
الله
هيثم،
يكرمك.
انا برضو مش هقول لك اللي انا اكتر من ان انا سعيده جدا جدا بحضرتك. حضرتك ادرت
أنا
الجلسه بمنتهى الاقتدار، بمنتهى
الله
العلم،
يخليك.
بمنتهى التحضر. ويعني انا النهارده يعني مش عارفه يعني اقول ايه، اطير في السماء مثلا واقول ان انا براوند ان انا كنت قاعده مع 2 جريد بروفيسور بالشكل ده.
الله
بصراحه
يخليك.
يعني انا امي
بارك
داعيه لي
الله في
والله.
حضرتك يا دكتور.
ربنا يبارك فيك.
بارك الله في حضرتك. احنا يعني احنا كل اللي عملناه ان احنا بس followed your arrangements, followed your superb arrangements. وانا بحب اقول بس ان طبعا اللي خلاني طبعا غير طبعا معرفه الدكتور ياسر، وان انا اتشرف ان ابقى مع الدكتور ياسر.
ده شرف لنا والله يا دكتور هيثم.
والله ده حقيقه يعني شرف للجميع. بس انا برضو اللي حسيته من الدكتوره صفاء she was very willing and to conduct your experience and your expertise for the junior. فده برضو for the junior colleagues الحقيقه all of us we should appreciate that. And it was really, I mean, I was shamed لو انا if I didn't accept her invitation, because I felt that she needs to conduct and to convey a message, to convey some data for the junior colleagues. So that's what makes me really wants to be part of this very nice and very heavyweight scientific course. So يعني شكرا دكتوره صفاء، وتشرفنا بحضرتك وتشرفنا دكتور ياسر. As usual, I'm not surprised دكتور ياسر يعني is a very talented speaker, very superb teacher and educator, and I will be delighted to be with as a part of in the floor as a candidate. Thank you so much for all of you.
ده الحقيقه. برضو انا هضطر اقول المفاجاه العظيمه ان شاء الله ان احنا الجمعه 3 يونيو we'll have our great professor هيثم الجميل in a very elegant lecture and we are waiting for him.
الله يخلي حضرتك. It's my pleasure دكتور صفاء.
ان شاء الله.
My pleasure to meet you again, to meet دكتور ياسر and to meet all of our junior colleagues. الله يخلي حضرتك يا دكتور.
ان شاء الله.
تحت امر حضرتك.
شكرا جزيلا. شكرا لحضراتكم.
شكرا
جزيلا.
شكرا شكرا. مع السلامه. السلام عليكم دكتور هيثم. السلام عليكم دكتور صفاء.
مع السلامه.
شكرا جزيلا دكتور ياسر. السلام عليكم. شكرا
مع
دكتور ياسر. شكرا دكتوره صفاء.
مع السلامه.
السلام عليكم.
مع السلامه.